Good morning, everyone. This is part B of chapter 18 on the heart. So, cardiac muscle contraction occurs, there's quite a few significant differences between cardiac muscle contraction and skeletal muscle contraction, but there are some similarities. The similarities include the fact that depolarization opens voltage-gated fast sodium channels in the sarcolemma. Remember, the sarcolemma is the cell membrane on a muscle cell. There will be a reversal of membrane potential from minus 90 millivolts to plus 30 millivolts, and this is a very brief occurrence caused by sodium channels then closing quite rapidly. The depolarization wave goes from down the sarcolemma to the T tubules, and this will be then transferred to the sarcoplasmic reticulum that store calcium ions, and that they will release this calcium ion. The calcium ion will remove the inhibition of the interaction between actin and myosin, and so this then will lead to excitation contraction coupling, where you get that calcium ion binding that troponin, the inhibition. The filaments will slide away from the actin reactive sites, and then myosin can engage. Now, with cardiac muscle contraction, there's several differences. There are about 1% of the cardiac muscle cells, they're called cardiomyocytes, they actually exhibit automaticity or autorhythmicity. That means on a rhythmic basis, they will spontaneously depolarize. They don't need nervous system stimulation whatsoever. And these can depolarize the entire heart in a very organized fashion. The cells of the chambers contract and relax as a unit. This is very important to remember. And there's a long absolute refractory period, about 250 milliseconds. It's long relative to skeletal muscle refractory period anyway. And this prevents a tetanic contraction. Remember, a tetanic contraction is a sustained contraction. If the heart muscle does that, you would not survive very long. The heart muscle needs to contract entirely. The chambers, first the atria, then the ventricles, and then it needs to relax entirely in order to allow blood to return to the heart. The depolarization wave also opens slow calcium channels in the sarcolemma. This is not present in skeletal muscle. The sarcoplasmic reticulum also releases calcium ion. And this calcium surge altogether, particularly due to the calcium ion channels in the sarcolemma, will prolong that depolarization phase, leading to a plateau. The action potential and contraction of the heart muscle lasts longer, and that allows blood ejection from the heart. Repolarization is when calcium channels are inactivated and the potassium voltage-gated channels are opened, and then of course calcium ion will be pumped not only into the sarcoplasmic reticulum but also extracellularly out to the outside of the cell. Now this is a kind of small, but it's a really good illustration, and this shows you the differences between skeletal and cardiac muscle physiology. You won't find this figure in your book, but I did include it as a JPEG, an image within your Canvas module. So they're comparing here. Here's skeletal muscle, here's cardiac muscle. So the action potential of a skeletal muscle is caused by opening fast sodium channels, Most of these are going to be voltage gated, but remember at the area where there's where acetylcholine binds to skeletal muscle, you've got the those sodium gated channels that open due to the binding of the neurotransmitter. And so this is showing you a typical skeletal muscle action potential. And the yellow and the kind of light green are representing the refractory periods. Green would be the absolute refractory period, and then the yellow is showing the relative refractory period. I like this better than the figure in your book, because over here we're showing actually electrical events. Okay, we've got the depolarization. This figure is showing the resulting contraction. So your y-axis is the development of tension in the muscle. But both have time in milliseconds as the x-axis. So here is this very, very short period of time where you have an absolute refractory period, meaning that another action potential will not cause another depolarization, because the sodium voltage gated channels are already wide open. There's a lot of positive ion on the inner surface of the cell. You see how this is actually the resting membrane potential, and then depolarization is when a lot of this the sodium ion is flooding into the cell, and then the sodium voltage, the gated channels close. Potassium then will be pumped out very readily, and so now we have a repolarization back to that resting membrane potential. Don't worry too much about this number down here. Different places you'll see minus 90 or minus 85 or even minus 70. They're showing minus 85 here. And here they're showing actually minus 90. So different cells actually have a little bit different of a difference in their resting membrane potential. Now let's take a look over here at the cardiac muscle. This is what's called that plateau. So the cell will depolarize, and then it's not going to repolarize right away. It's actually going to stay depolarized along this plateau. And then they're showing here the resulting contraction in a separate graph down here. So this is showing the steps of the cardiac muscle action potential. Step 1, rapid depolarization caused by sodium entry. It lasts about 3 to 5 milliseconds. It ends with the closure of the voltage regulated or voltage gated sodium channels. Step 2 is this plateau. The cause is actually calcium ion entry. So here, not only does the calcium ion remove the troponin, tropomyosin inhibition, but here it actually is keeping that cell depolarized. It lasts about 175 milliseconds, and it ends with closure of this, what we call the slow calcium channels. Now we've got repolarization. Repolarization will, in both cases, skeletal and cardiac muscle, is due to potassium ions leaving that cell. Duration of this is about 75 milliseconds, and again, it ends with the closure of these potassium channels. Okay, so look at this long absolute refractory period, and there's even a longer relative refractory period. This figure from your book actually, again, I don't like this because they're showing you a y-axis, and it's labeled membrane potential in millivolts, and that would be applying to this action potential. This is actually tension development. So that, okay. All right, I'll give it to him. Here's showing on this side the tension. So here's the y-axis for the purple, magenta colored curve right here. But anyway, they're showing you the depolarization, the plateau, and the repolarization. And it's going over depolarization due to the sodium influx through fast voltage gated sodium channels. And this is that positive feedback cycle, that more and more sodium channels opening, actually reversing that membrane potential so that it's not only not negative on the inner surface, but it actually becomes positive along that inner surface of the cell membrane, the sarcolemma. So then they're showing you the plateau phase due to the calcium influx through slow calcium channels, and this keeps that cell depolarized because there's not very many potassium channels open. Repolarization is due to the calcium channels inactivating and then potassium channels opening. This is what's allowing the potassium to leave. That's called efflux. Think of exit, which brings the membrane potential back to its resting voltage, the resting membrane potential. So there's a very great demand for energy in cardiac muscle. But what are some of the adaptations? There are many mitochondria, and if you'll remember, mitochondria allow aerobic respiration to occur. So there's very little anaerobic respiration that occurs with cardiac muscle, but it can actually switch to other fuel sources, even using lactic acid if necessary. Your heart muscle cannot take a break. It needs to contract fully and then relax and then allow blood to fill, but then it needs to keep contracting. Otherwise, you would die. So it needs a lot of energy. There's a lot of adaptations that help it do that. But if the muscle cells lack oxygen, the term for this is ischemia, then anaerobic respiration will begin to occur. But keep in mind, anaerobic respiration leads to lactic acid production in muscles, and this creates an acid, very high hydrogen ion concentration, which can lead to mitochondrial damage. The gap junctions would close, and this can lead to fatal arrhythmias. So, the electrical events of the heart. The heart muscle depolarizes and contracts without nervous system stimulation. Remember, with skeletal muscle requires that neuromuscular junction where the acetylcholine, that neurotransmitter, is released from the presynaptic cell, the motor neuron, and it binds to the muscle cell in order to start or to lead to an action potential and then contraction of that muscle cell. But with cardiac muscle, it doesn't require nervous system stimulation. However, the rhythm can be altered by the autonomic nervous system, abbreviated ANS. And remember, the two parts of autonomic nervous system would be sympathetic nervous system during that fight or flight response when the body is activated, or parasympathetic nervous system when your body is at rest. So the heart will definitely be influenced by these two divisions of the autonomic nervous system. The heart needs to have a coordinated heartbeat. This involves the gap junctions so that the action potential will be traveling between cells. And it's done and controlled through what we call the intrinsic cardiac conduction system. There is actually a network of non-contractile cells that are autorhythmic. They initiate and distribute the impulses throughout the heart in a very organized fashion, normally. Now, the pacemaker of the heart is, this is a little cluster of autorhythmic cells. It's actually in what we call the sinoatrial node in the upper right-hand corner of the right atrium. This is where it's going to start. You'll see this in a minute. But these cells have an unstable resting membrane potential. This is called the pacemaker potential or prepotentials due to a spontaneous opening of slow sodium ion channels. They spontaneously depolarize. So the three parts of the cardiac action potential would be the pacemaker potential. This is that slow depolarization due to the opening of slow sodium channels and the closing of potassium channels. Then you have the depolarization when calcium channels open and it creates a huge influx of calcium ion leading to a steep rise in the action potential. and then repolarization, which is when the potassium channels open, causing a very rapid efflux or exit of the potassium ion. So this is showing the pacemaker and action potentials of the pacemaker cells in the heart. So just keep in mind, this is happening on a continual basis with these autorhythmic cells in the cardiac conduction system. Pacemaker potential is the slow depolarization due to both opening of sodium channels and closing of potassium channels. Notice that the membrane potential is never a flat line. It's just doing its thing, spontaneously depolarizing and repolarizing. So depolarizing is shown right here in 1, pacemaker potential, right here, where it slowly goes, depolarizes, and then this is actually considered the depolarization. The action potential begins when the pacemaker potential reaches threshold. So this is due to calcium influx through calcium channels. Repolarization here, this is due to calcium channels inactivating and potassium channels opening. This potassium efflux is going to bring that membrane potential back to the most negative voltage. So what you really will need to know is the sequence of excitation in the heart. The cardiac pacemaker cells will pass the impulses. This is what I mentioned before, the sinoatrial node. Sino is a sinus is like a little space there, a little cluster of cells, and this is in the upper right-hand corner of the right atrium. This is often called SA node as well. So this is where this impulse starts with these autorhythmic cells. This signal will then be sent to an atrioventricular node, which is a little cluster of cells at the junction between the atria and the ventricles, close to the center of between the ventricles. Then it goes to the atrioventricular bundle, which goes down through that interatrial septum and then the interventricular septum. The atrioventricular bundle goes to the right and left bundle branches, which are definitely going all the way down through the interventricular septum. And then that goes to what we call now the subendocardial conducting network. And this is also called these are called Purkinje fibers also. So we're going to go over this step by step. First of all, with the sinoatrial node, we call this the pacemaker. I kind of like to think of it as like the conductor of an orchestra. So it will set the pace as far as how quickly the heart is going to beat. All right, sometimes your heart needs to be slow. The heart rate is slow when you're sleeping and not being very active. But there are times where the heart rate needs to speed up when you are during activity, when you're exercising, and also if the body is alerted to some kind of a danger. So this pacemaker in the upper right-hand corner of the right atrium, it depolarizes faster than the rest of the myocardium. This is what we call sinus rhythm. And you may have heard this like on TV shows like ER or different kinds of shows where they'll say normal sinus rhythm. You may have heard this, and that just means that the heart is in normal sinus rhythm. Typically, this rate is around 100 times per minute, but it's tempered by extrinsic factors, meaning by the influence of other things that are interacting with it, such as the sympathetic nervous system or the parasympathetic nervous system. From the pacemaker, this impulse will spread across the atria, will depolarize the atria, and then it will go to the AV node, or atrioventricular node. At the AV node, or atrioventricular node, this is actually in the interatrial septum. The impulse will be delayed very briefly. The fibers have smaller diameter here and fewer gap junctions, but just keep in mind that this is going to allow the atria to contract first. So as that impulse is spreading to the atria will contract. That signal is now at the AV node. The AV node has an inherent rate of 50 times per minute. From the AV node, now we're going down to the atrioventricular bundle. This is what used to be called the bundle of His. Looks like his, but it's pronounced His. It was named after Dr. His. But this is a segment that goes from the AV node downward. It's in the superior interventricular septum, and it's the only electrical connection between the atria and the ventricles. It has an inherent rate of about 30 times per minute. Then it divides into the right and left bundle branches. These are the two pathways that are all clearly within the interventricular septum. Then the impulse spreads to what they now call the subendocardial conducting network, and these are often referred to as Purkinje fibers, and they used to be known as the Purkinje fibers, named after Dr. Purkinje. This completes the pathway. And so what these do is they go all the way up from the apex of the heart down at the bottom of the interventricular septum, or toward the most inferior part, and then they spread all the way up throughout the ventricles. They are more elaborate on the left. And when you see the picture, it'll make more sense. So the ventricular contraction is going to be immediate after the action potential occurs, or the nerve impulses here. The ventricular contraction goes from the apex of the ventricle, of the heart, all the way up toward the atria. So this is actually showing you in gold. This is representing the pathway, the intrinsic cardiac conduction system, and the action potential succession during one heartbeat. So here's the sinoatrial node generating the impulses, and then you have your the spread of the action potential to both the left and right atrium. It goes down. This is representing the atrioventricular node, a little brief delay, allowing the atria to contract, and then it will spread down through here from the interatrial septum down to the interventricular septum, and it's called the atrioventricular bundle, or the bundle of His. And then it will continue, it splits into the bundle branches, the right and left bundle branches, down that interventricular septum, and then this will now spread out throughout each of the ventricles. It's called the subendocardial conducting network, and these are going to depolarize the contractile cells of both ventricles. This is what's also known as Purkinje fibers. They're showing you right here. And it's not just in this one plane, it's actually throughout each of the ventricles. So there defects in this intrinsic conduction system may cause arrhythmias, uncoordinated contractions, and what's known as fibrillation. A defective SA node can allow what's called an ectopic focus to take over. Ectopic just means it's not in the right place. It could be the AV node. If the AV node takes over because the sinoatrial node's not working properly, you will have what's known as junctional rhythm. Extrasystole. These are also known as PVCs, pre-ventricular contractions. Oh, the ectopic focus is a high rate. It's not a high rat. But anyway, this ectopic focus is going to be somewhere in the heart that's stimulating a very fast rate. It can happen briefly. It can be caused by too much caffeine. It can be caused by dehydration. Most of us have experienced a PVC now or then in our lives, and it kind of feels like your heart's pounding out of your chest cavity, because actually the heart in the body is somewhat tipped, so that the apex is going anteriorly, and when the heart beats very strongly, it kind of pounds against the anterior chest wall. There can also be a defective AV node. This is called heart block, and the impulse must pass through the AV node. There's also extrinsic innervation of the heart. The autonomic nervous system has the cardiac centers in the medulla oblongata of the brain. The sympathetic nervous system fibers will increase the rate and force of contraction. Parasympathetic nervous system fibers decrease the rate. The cardioacceleratory center in the medulla oblongata is part of the sympathetic nervous system that will influence the SA node, the AV node, the heart muscle, and the coronary arteries. And it actually increases the heart rate and strength of contraction or force of contraction. Cardioinhibitory center in the, is part of the parasympathetic nervous system. It inhibits the rate of the SA node and the AV nodes, and it is going to be due to actually the vagus nerve. The vagus nerve is part of this cardioinhibitory center. And this is showing you the vagus nerve over here, part of the parasympathetic nervous system, which will influence the heart rate, slowing it down. And then this is showing the cardioacceleratory center, where you have, in gold here, it's showing that it's through the sympathetic nervous system. It will, it's now the first pre-ganglionic neuron, we call this, will synapse with another neuron, which goes out to the heart and will actually speed up the heart rate and increase the force of contraction. Electrocardiography. It used to be EKG because cardio in German starts with a K, K-A-R-D-I-O, but now we know it as ECG, electrocardiography. This makes more sense in the English language because we spell cardio with a C, ECG, but you may say EKG. This is a composite of all the action potentials generated in the heart at a given time. The signals that are given off are electrical signals. And so you will need to know the parts of the EKG and what they represent. The P wave represents the depolarization of the atria. The QRS complex represents ventricular depolarization. Now remember, when cells depolarize, they must repolarize. And so during this QRS complex, this is reflecting ventricular depolarization, but also atrial repolarization is occurring at this time, but you don't see any indication on the tracing. But then you'll see a T wave, which is a little bump, and that reflects ventricular repolarization. When I say bump, I'm talking about the tracing, and it's easier when you actually see the figure. So this is showing the pink lines are representing the flow of electricity through that intrinsic cardiac conduction system in the heart. And then this will lead to depolarization of the various parts of the heart. So P, this is representing atrial depolarization. Then you have a short interlude, a short period of time before this impulse gets to the ventricles, and the QRS complex represents the flow of that action potential throughout the ventricles. And then we see another little bump. This is the bump I mentioned before. This bump on the tracing represents repolarization of the ventricles. They can actually, a specialist in this area can diagnose abnormalities of the PR interval, the ST segment, and the QT interval. So by looking at these and examining the tracings, there can be pretty accurate diagnosis of any type of arrhythmia in the heart. Arrhythmia means when the heart is not beating in the correct, either at the correct rate. It could be very, very fast, very, very slow, or irregular. So this is showing you the gold color right here is representing what's happening during the green part of the tracing. Atrial depolarization is initiated by the SA node, and this is then flowing to the atria, and that's the P wave right here. 2. With complete atrial depolarization, then the impulse is delayed briefly at the AV node. There's the little green part of that tracing. Then we have this leading to ventricular depolarization beginning at the apex. So this impulse goes down the bundle of His, or the atrioventricular bundle, to the left and right bundle branches, down out to all the subendocardial conducting network, out to all the cells in the ventricles. So ventricular depolarization then begins at the apex. It's flowing out to all the cells here. And then, so that's showing you this QRS complex. And now it's complete over here, number 4. Ventricular depolarization is complete. And then we have, we've got a brief delay right here. But after the ventricles depolarize, of course, that's going to lead to the contraction of the heart. But then the ventricles, of course, will be repolarizing. And that's showing repolarization of the ventricles, and that will show up on the tracing as the T wave right over here. They're showing the red is representing repolarization. Now, they did show you over here the atria are repolarizing during the QRS complex. So there is your EKG or ECG. And here's some this is a normal sinus rhythm, and these are showing you various types of abnormalities. This very, very grave situation of ventricular fibrillation is chaotic. Grossly irregular ECG deflections are seen. This is an acute heart attack. If this continues, it's a medical emergency. It's incompatible with life. And there's many other types of heart abnormalities that can be diagnosed looking at the ECG. Heart sounds. When you listen to the apical pulse, when you're listening with a stethoscope to the heart, you're actually hearing valve closure primarily. We call this lubbed up. Lub is when the AV valves, the atrioventricular valves, which includes, remember, the tricuspid valve on the right and the bicuspid or mitral valve on the left. Both of these are AV valves, and they close at the same time. Lub is occurring at the very beginning of what we call systole. Systole is when the ventricles begin to contract, and they're contracting. So lub is the AV valves close at the beginning of systole, and then dup is the closure of the semilunar valves, both the aortic and the pulmonary semilunar valves. This is at the beginning of diastole, when the ventricles are relaxing. Lubbed up. And that's what one complete heart beat, I'm putting beat in air quotes, one beat would be considered lubbed up. A heart murmur is when you will actually hear some kind of a leak, okay? That would be like when you hear the lubbed up and you hear a little kind of it would be actually turbulence that is caused by some type of a leakage in the valve. There could be backflow through one of the valves that is not closing properly. There could also be, if you're listening to the heart sounds and you hear an extra heart sound, instead of lubbed up, it would be like, instead of bump bump, it would be ba-ba-bump, ba-ba-bump. Sometimes it's called a gallop, because that's kind of like a horse galloping, da-da-dun, 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 like that. That is when one of the valves is delayed in closure, because it should be the lub, both atrioventricular valves closing at the same time, and the dup would be both semilunar valves closing at the same time. But if one is delayed, you could have this like a syncopation where you have da-da-dun, da-da-dun, and that would be considered an extra heart sound. And this is showing where each valve is heard most clearly. The aortic valve, and they're giving you the landmark second intercostal space at the right sternal margin, pulmonary valve over in the second intercostal space at the left sternal margin, and then here is the tricuspid valve. You can hear most clearly in the right sternal margin of the fifth intercostal space, and then the mitral valve over the fifth intercostal space, mid-clavicular line, which again, that's where we can also hear the apical pulse. Now, in today's medical world, with all of the diagnostic tools that we have available, medical practitioners are not quite as adept at listening for these heart sounds because there's a lot of diagnosis that can be done pretty definitively through ultrasound, echocardiography, and all kinds of non-invasive tests to determine heart functioning. So, the cardiac cycle. Cardiac cycle includes everything going on at the same time. So it often looks quite overwhelming, but just keep in mind that first there needs to be the electrical conduction to the various regions of the heart, and then the heart will respond with contraction and then relaxation, and also the valves are going to be closing and opening at various points throughout this cycle. Keep in mind this term, systole, it means contraction. And it has it looks like systole, but it's systole. It has a long E sound at the end. Diastole is relaxation. When we say systole and diastole, we're generally referring to the ventricles. So ventricular systole is when the ventricles are contracting, and ventricular diastole is when the ventricles are relaxed. And it's really important that they also relax because that's when blood flow can return to fill up the heart. Because there's no point in the ventricles to contract if they're not filled with blood. So there's actually a series of pressure and blood volume changes that are going on. Did I say usually? There always is a series of pressure and blood volume changes involved with this cardiac cycle. So I also have a complete handout for you that's included in your Canvas module on the heart, on the cardiovascular system. But we'll go through it right here too. We're just going to start out in one point. This is a cycle, so you need to choose a point. Where we're going to start is mid to late ventricular diastole. The ventricles are relaxed, the ventricles are filling. Because as blood returns to the atria, the atrioventricular valves are wide open, pressure is low in the heart, so blood is just going to be coming into the heart on both sides and actually will be filling the ventricles. About 80% of ventricular volume is just passive blood flow. But then the atria contract. That could be called atrial systole, and this is going to deliver the remaining 20% of the blood volume. At the very end of diastole, we call the volume in the heart, in the ventricles, end diastolic volume, abbreviated EDV. This is the volume of blood in the ventricle at the end of ventricular diastole. So this is while the ventricles are relaxed, and it's just before they contract. Ventricular systole. The atria relax, and the ventricles are now beginning to contract. This is going to increase the ventricular pressure inside, and that's going to lead to closing of the atrioventricular valves. It begins with what we call isovolumetric contraction. Very brief. So the ventricles are contracting, but right before the valves close, it's actually, right after the right after the AV valves close, the semilunar valves are not open yet. So when the ventricles are squeezing, okay, all the valves are closed. So therefore the volume inside doesn't change, but the ventricles are squeezing. They're beginning to contract. Then we have ventricular ejection. This is when the ventricular pressure exceeds the pressure in the large arteries, the aorta from the left ventricle, and then the pulmonary trunk from the right ventricle. And so and as soon as those semilunar valves open, the blood will be ejected from the ventricles into the large vessels. As soon as the blood is ejected, after ejection, what's left in the ventricles is called end systolic volume. So the ventricles, they begin to contract, then the semilunar valves open, blood is ejected. So what's left? There'll be a little bit left in the heart, in the ventricles, and what this volume of blood is called end systolic volume. Then, very briefly, you have isovolumetric relaxation. Very early diastole, the ventricles and the atria are relaxed, and blood is going to start entering. There's a backflow of blood in the great vessels, and this closes the semilunar valves. So, when the ventricles are relaxed, just before the mitral valve opens, or the AV valves open, and so they're still closed, and then the semilunar valves are all closed, and the ventricles are fully relaxed for a very, very brief time. That's going to lead to opening of the AV valves. And there is a pressure change. It's called the dicrotic notch. I'm going to explain this when we look at the figures. So what we're looking at is different pressures within the heart. But the backflow of blood in the great vessels closes the semilunar valves. You get this little notch on the pressure tracing. The ventricles are closed until the AV valves open. When the atrial pressure is greater than the ventricular pressure by blood returning into the atria, that's going to cause the atrioventricular valves to open, the tricuspid and the mitral valves. So this looks quite overwhelming. There's a lot of things going on, but this is a summary. The summary of events during the cardiac cycle. So this would be your EKG or ECG, the P, Q, R, S, and T blips on your tracing. Then you have the heart sounds, lub, dup. This is showing the pressure. Remember, pressure is measured in millimeters of mercury, and you've got your, in the aorta, the green would be representing the pressure in the aorta, the blue is representing the left ventricle, and then the magenta line is atrial pressure. So I'm not going to get into this a lot on the graph, but all these things are going on at the same time. I generally like to talk about them separately. Here, this is the pressures within various structures. This is ventricular volume. So this would be the volume of blood in the ventricles. So this is when the valves are open and blood is returning to the heart, first the atria, and then it comes right into the ventricles. And then when you get ventricular or systole, the blood will then be ejected from the ventricles, and then you have blood returning to the heart and the ventricle. That means the atria and the ventricles, and the blood volume will go up. This is showing the actually the filling of the blood. Then it shows you atrial contraction, isovolumetric contraction phase, where the ventricles begin to contract, but all the valves are closed. And then you get ventricular ejection, which corresponds to, actually it doesn't really correspond up there, but it's actually when the blood is being squeezed out. And then right before the valves open, the ventricles are relaxing. And then when that pressure goes down in the ventricles, below atrial pressure, it's going to allow the atrioventricular valves to open again, and then blood will continue to fill the ventricles. Okay, I also have a text summary on a handout that you can look at as far as the cardiac cycle. This concept is called cardiac output, abbreviated CO in this situation. Carbon monoxide is also CO, but here it means cardiac output. This is the volume of blood pumped by each ventricle in 1 minute. Cardiac output equals heart rate. That means how many times per minute the heart is ejecting blood. We call it a heartbeat, but I don't really like that term that much. But your heart rate times the stroke volume, abbreviated SV. So if I put in here heart rate, whatever the given heart rate, times the stroke volume will be your cardiac output. Normally, cardiac output's about 5.25 liters per minute. And so here are some examples. At rest, your cardiac output would be your heart rate, let's just say 75 beats per minute, times a stroke volume of 70 milliliters per beat, and this will equal 5.25 liters per minute. That would be the cardiac output. Cardiac output will increase if either the stroke volume or the heart rate increases, or both. The maximal cardiac output is about 4 to 5 times a resting cardiac output. Maximal cardiac output is up to 35 liters per minute in a trained athlete. Cardiac reserve would be the difference between your resting and your maximal cardiac output. So how do we, there's two things that can be regulated: stroke volume and heart rate. So stroke volume is your end diastolic volume, the volume of blood in the ventricle just before the ventricle begins to contracts, all right? And the semilunar valves open and is allowing some blood out. So this end diastolic volume minus the end systolic volume, what's left in the ventricle after they've contracted, will be called the stroke volume. So, and basically that stroke volume is how much blood is ejected by the heart per heartbeat, or each time the heart contracts. End diastolic volume is affected by the length of ventricular diastole, how long the ventricles are relaxed, and also venous pressure. End systolic volume is affected by arterial blood pressure and the force of ventricular contraction. There's 3 main factors that affect stroke volume. 1, preload, 2, contractility, and 3, afterload. And we'll go through each one of these. Preload is defined as the degree of stretch of the cardiac muscle cells before they contract. This is called the Frank-Starling law of the heart, and there's 2 doctors, Dr. Frank and Dr. Starling, that pretty much devoted their lives to studying these principles. So it's actually the length, there's a length-tension relationship. So if a muscle cell is not stretched at all, or if it's stretched too far, it will not have as much contractility as if there is a stretch of that muscle fiber. So preload is defined as the degree of stretch of cardiac muscle cells before they contract. At rest, the cells are shorter than optimal. So the most important factor to this stretch would be how much blood's returning to the heart, venous return. During exercise, there's a very much increased amount of blood returning to the heart. If you think about squeezing those muscles, any blood out in the periphery of the body will be then sent back to the heart. So exercise will increase venous return. Increased venous return distends or stretches the ventricles and increases the force of contraction. So this is often referred to as the Frank-Starling law of the heart. Contractility, this is the contractile strength at a given muscle length independent of muscle stretch and end diastolic volume. It will be increased by sympathetic nervous system stimulation because it's going to increase calcium ion influx, allowing more cross bridges to form. Also, positive inotropic agents. Ino in Latin means fiber. So this is the contractility of the cardiac muscle fibers. Agents that have a positive inotropic effect would be thyroxine, glucagon, epinephrine, the medication digitalis, and also an increase of extracellular calcium ion. These will increase the contractility of that muscle fiber, make it a stronger, or increase its strength of contraction. Contractility is decreased by negative inotropic agents, including acidosis. That means the blood becomes too acidic. An increase in extracellular potassium ion and calcium channel blockers. So there's medications that can decrease the contractility of the heart muscle cells. And this is showing you how norepinephrine increases heart contractility via what we call a cyclic AMP second messenger system. It's actually, this is supposed to be two words there. So there is norepinephrine will bind the cell membrane on a muscle cell, and it will actually bind to a beta-1 adrenergic receptor and will pass this along through carriers in the cell membrane. And it's actually going to activate the cyclic AMP system, and we haven't gotten to this yet because we haven't talked about the endocrine system, but this is turning an inactive protein kinase to an active protein kinase, and this will actually allow that cardiac muscle cell to increase its force and velocity, how quickly this is happening. We discussed this concept more in detail when we get to the endocrine system. But just keep in mind that norepinephrine, which is similar to epinephrine or adrenaline, this is going to increase heart contractility because it will actually bind to these heart muscle cells, allowing the contractility to increase through intermediary molecules. So there's the third factor in regulation of stroke volume, how much blood is ejected by the ventricles per stroke. This is called afterload. So this is the pressure against which the ventricles must eject the blood. So the pressure, this afterload is the pressure the ventricles must overcome to eject that blood. Hypertension or high blood pressure increases afterload. It increases end systolic volume, and therefore it will decrease stroke volume. So because there's such a high pressure into which the ventricles have to eject the blood, it's going to increase the amount of blood left in the heart after systole. Regulation of heart rate. There's our positive chronotropic factors that will increase heart rate. Chrono, think of chronological. This is in time. There are positive chronotropic factors that increase heart rate and negative chronotropic factors which decrease heart rate. Chrono is having to do with the time sequence. So this chronotropic factors affect the heart rate. Okay, autonomic nervous system regulation. Sympathetic nervous system is activated by emotional or physical stressors. Norepinephrine, also known as noradrenaline, binds those beta-1 adrenergic receptors. This is actually going to increase your heart rate, increases heart muscle contractility, and then the heart muscle also will be able to relax more quickly. This also increases the pacemaker rate, or remember the sinoatrial node, that is the pacemaker of the heart, and sympathetic nervous system will increase that rate. It also causes the release of epinephrine from the adrenal medulla. So during the activation of sympathetic nervous system, these sympathetic nervous system fibers will actually synapse with the adrenal gland in the adrenal medulla, releasing adrenaline into the bloodstream, and this amplifies the whole effect. Adrenaline in the bloodstream will also increase the heart rate by affecting the sinoatrial node. The parasympathetic nervous system opposes the sympathetic nervous system effects. Acetylcholine that's released by parasympathetic nervous system neurons hyperpolarizes the pacemaker cells, and this brings down the heart rate. Acetylcholine has no effect on contractility. There is something that we call vagal tone. This is because the vagus nerve is part of the parasympathetic nervous system, and it will keep the heart rate slow. So at rest, the heart is in what they call vagal tone. The parasympathetic nervous system is the dominant influence. There's something called the atrial or Bainbridge reflex. This is a sympathetic nervous system reflex initiated by increased venous return. When there's an increased venous return, it's going to stretch the atrial walls, which is going to stimulate the SA node, increasing heart rate. The atrial stretch receptors are activated. Now, this is actually, clinically, you can appreciate this. If you take a deep breath, it's going to very briefly increase the heart rate, because when you take a deep breath, you're opening the thoracic cavity, basically bringing more blood back to the heart. So you'll have an increase in venous return to the heart, stretching the atrium, activating your atrial stretch receptors, and it's going to increase your heart rate very temporarily. There's another way that many people believe you can alter your heart rate, and that is to help you relax. What you do is you take in a breath through the nose and then very slowly breathe out through pursed lips. That means you make your lips really tiny. So if you breathe through the nose and breathe through pursed lips, it's creating a little bit of a pressure, and it can actually help you relax. And so it's interesting that the respiratory system can actually affect heart rate. And this is showing you a summary of factors involved in determining cardiac output. And this is showing you exercise by increasing sympathetic activity, increased skeletal muscle in the respiratory pumps. Also, if you have a decreased heart rate, allowing for more time for ventricular filling, you're going to increase venous return, increasing your end diastolic volume, and this is going to increase your stroke volume. This is showing blood-borne, that means hormones like epinephrine or thyroxine or excess calcium in the blood increases contractility of the heart. It's actually going to decrease end systolic volume. That means there'll be more blood ejected by the heart, and this is going to increase stroke volume. Exercise, fright, and anxiety also increase sympathetic nervous system activity and decrease parasympathetic nervous system activity, thereby increasing your heart rate. Both increasing the stroke volume and or increasing heart rate increase cardiac output. Chemically, hormones are considered chemicals. So epinephrine, secreted by the adrenal medulla, increases heart rate and contractility. Also thyroxine, T4, which is the one of the hormones produced by the thyroid gland. It actually increases heart rate, and it also increases the effects of epinephrine. Intracellular fluid and extracellular fluid ion concentrations must be maintained at their proper levels within homeostasis. Hypocalcemia, low blood calcium, can decrease heart activity. Hypercalcemia, high calcium, blood calcium level can increase heart rate and contractility. Hyperkalemia. Remember, potassium has the symbol K because kalemia, kalem refers to potassium. So hyperkalemia is high blood potassium. This alters electrical activity. It can lead to heart block and cardiac arrest. Actually, in the lethal injection, potassium is injected along with other drugs to stop the heart. So high blood potassium is dangerous, but also low blood potassium, hypokalemia. This will decrease heart rate, and it can lead to fatal arrhythmias as well. Other factors that influence heart rate. Age. The fetus actually has a much faster heart rate than the adult, and that's how sometimes if a woman, while she's pregnant, you can listen down by the uterus, and you can sometimes pick up the fetal heart rate. The doctor in the clinic, they will always listen for the fetal heart rate, and that can be differentiated from the maternal heart rate because it generally is much faster. Gender. Female heart rate is typically faster than the male when they're in the same conditions, so typically we'll look at resting heart rate. Exercise, of course, will increase heart rate. Body temperature also increases heart rate. So even at rest, if someone has a fever, they'll have a much higher body metabolism, and their heart rate will be higher as well. Tachycardia. This is defined as a heart rate at rest of greater than 100 beats per minute. This can lead to fibrillation. Bradycardia is when the heart rate is less than 60 beats per minute. This can lead to inadequate oxygenation. But there are many athletes who have a resting heart rate in the 50s. And so this could be a desirable result of athletic training. But typically, a heart rate lower than 60 would be defined as bradycardia. Congestive heart failure. This is a progressive condition, and this is when cardiac output is too low or inadequate to meet the body's needs. CHF is how we abbreviate it, congestive heart failure. This is typically caused when there's a weakened myocardium or heart muscle caused by coronary atherosclerosis or arteriosclerosis. This is when the coronary arteries are narrowed by plaques, and it's just reducing the amount of blood flow that can get to the myocardium. This can actually be caused by persistent hypertension or high blood pressure, damaging the inner lining of these small blood vessels. Multiple myocardial infarcts. A myocardial infarct is a blockage in one or more of those coronary arteries. Also, there's signs of a dilated cardiomyopathy, meaning an enlarged heart. Cardiomyopathy is a disorder of the heart muscle itself, and when you see an enlarged heart, it's when this heart muscle is dilated or enlarged and it can't pump as efficiently. Congestive heart failure can lead to pulmonary congestion, and this is considered left side failure because the blood coming back to the left atrium, there's a pressure, a backup of fluid in the lungs, and the fluid can seep out from the bloods and cause pulmonary edema. Peripheral congestion is right-sided failure, and this is when there's a back pressure out in the body, in the venous system, and the blood will pool in the body organs. Failure of either the left or the right side will weaken the other. It's treated by removing excess fluid. They would administer some kind of a medication that would allow them to excrete more fluid. A diuretic is what we would call that. And they also, you want to decrease the afterload. So some type of medication which would decrease their blood pressure, because typically if you have high blood pressure, that's increasing the afterload. So if you can bring the blood pressure back down to normal, that will bring down the afterload. Also, medications can be given to increase heart contractility and allow those heart muscle cells to contract more effectively. Developmentally, we're not going to get into a lot of developmental aspects of how the heart develops, but it's quite fascinating and complex. There are embryonic heart chambers, and remember we have the 4-chambered heart, so they're showing all the different events that need to happen in order to form the 4-chambered heart with the normal circulation. In the fetal heart, though, there's a few important structures that you will actually be examining in the lab on the heart model. There is, between the left and right atrium, there's a little area that's kind of indented. It's called the fossa ovalis. And prenatally, it was actually an opening called the foramen ovale between the right and left atrium. And then in the fetus, there's a ductus arteriosus that is actually a little duct that connects the pulmonary trunk to the aorta, because blood flow will be shunted to different areas prenatally, because blood that's going to the lungs is not going there to become oxygenated, because remember, the fetus is actually floating in amniotic fluid. But the remnant of the ductus arteriosus is called the ligamentum arteriosum, and you will see that on the heart models, and you'll need to identify that on the lab practical. Congenital heart defects are one of the most common birth defects, and most of them can be surgically treated or corrected. Most are of one of two types: the mixing of oxygen poor and oxygen rich blood. This would be atrial septal defect. That's when remains an opening between the atria. PDA is patent ductus arteriosus. In other words, the ductus arteriosus does not close to become the ligamentum arteriosum. It actually stays open. This can actually happen near the end of pregnancy if a woman is taking ibuprofen. This can actually lead to that ductus arteriosus staying open instead of closing as it should. There's also narrowing of the valves or vessels. This is called coarctation of the aorta, where there's a narrowed area in the aorta. And there's one type of congenital heart defect that includes 4 different things. And so therefore tetralogy of Fallot. That means 4 different heart pathologies. And again, we're not going to go into a lot of the details of congenital heart defects at this point. But here's showing you, there's also another thing called ventricular septal defect. This is when there's an opening between the right and the left ventricle. And the blood can go from the right to the left, or the left to the right. More blood's typically shunted from the left to the right because the left ventricle is stronger. Coarctation of the aorta, they're showing it's very narrowed right up here. And that increases the workload of the left ventricle. And this is actually showing you the tetralogy of Fallot. Dr. Fallot was the physician who described this. There's multiple defects. Pulmonary trunk is narrow and the pulmonary valve is stenosed. And then you've got a hypertrophied right ventricle. You've got a VSD present. And then the aorta opens from both ventricles. So this is relatively rare, but it can happen. Age-related. There can be sclerosis or hardening and thickening of the valve flaps. You can get a decline in cardiac reserve and fibrosis of the cardiac muscles, so the myocardium is not able to contract as effectively. Atherosclerosis is also called arteriosclerosis, where the arteries, the vessels, particularly the smaller ones, they get thicker and hardened. And that is the end. Have a wonderful day. I will see you at the next lecture, or you will hear me.